Ladies and gentlemen, boys and girls, artificial intelligences and machine learning entities, welcome to the Healthcare Innovation Summit Africa 10th edition. I think just for the sake of formalities, I wanted to personally and cordially say thank you for making the time. I think that today in particular is going to be an interesting day. I stand here and I see a lot of you visionaries, a lot of you custodians, a lot of you guardians of the healthcare sector. And I'm glad to say that our lineup we have today of our distinguished guests is definitely going to be thought-provoking. It's definitely going to be insightful. We're talking about healthcare and innovation. We're talking about the issues in the sense of the congruencies and parallels, what supports, what mitigates, what causes issues, and I'm sure and certain that after we have finished with the dialogue, you will leave richer and more fulfilled and more knowledgeable than when you had started. Without further ado, my good people, I'd like to call upon the first speaker. I have the pleasure of introducing Dr. Richard Friedland, the Group CEO at Netcare. As the Group CEO of Netcare, he leads the largest and most ambitious healthcare digital and data transformation across Africa for the past 6 years as part of a 10-year strategy to radically transform the way healthcare is delivered in South Africa and across the continent. We all know Netcare. Netcare has digitized all of its offerings, platforms, emergency services, ACASO, cancer care, occupational health, and is now using clinical data to improve outcomes, patient safety, and AI-driven machine learning. Ladies and gentlemen, put your hands together. Round of applause for Dr. Richard Friedland.
I'm going to talk about our Netcare strategy around person-centered healthcare that's digitally enabled and data-driven. And the purpose of really doing that is very, very simple. It's not because of digitization per se, but why it's important to digitize, why it's important to embrace this data journey, and how critical it is for all of us in healthcare, not only in South Africa as healthcare players, but certainly within the African continent and globally, to digitize as fast as possible. And I'm going to begin by making a statement that's probably going to shock you, but here it is. Globally, the provision of healthcare in terms of providers and the relationship between us and funders and patients is fundamentally flawed. Healthcare is broken. It's absolutely broken. Whether you're in the public sector, whether you're in the private sector, whether you're in South Africa, anywhere else in Africa, whether you're in the United Kingdom, Europe, Asia, or the United States. Why do I say that? Globally, the costs of healthcare have spiraled out of control. And I'm going to show you a few slides to demonstrate that. And yet we've made very, very little impact on addressing non-communicable diseases in all of our countries and diseases of lifestyle and chronic illness. Now, Peter Attia is an absolute guru of wellness and what he calls health span. You may have read his book, Outlive. And he says that we're very good in early medicine, in medicine today, modern medicine, with fast death. You come in with a heart attack, we can give you a stent. You break your bone, we'll fix your bone. But we're pretty lousy at what he calls slow death, treating diabetes and hypertension and those kinds of conditions. And this is a graph from his website, which is quite informative. We're living a decade longer, plus minus. But actually our health starts declining, our health span, from about the age of 40. If you're a runner, you'll know that you recover from injuries until you're 40, and then after 40 you start accumulating them. And that's the relationship between longevity and lifespan. Let's have a look at the United States, considered with Switzerland and Germany to have the best outcomes in the world. Well, healthcare life expectancy has gone up 11%, but per capita costs in real terms have increased 700%. Does that sound like value for money? If you look at it, more than 50% of deaths in the United States are non-communicable diseases. This is why healthcare is broken. Take a look at it with the NHS, that's purported to be probably the best public healthcare system in the world. An increase in 700% in healthcare costs since 1970, and a 12% increase in longevity. And have a look at this. Not 50%, but 2/3 of deaths in the United Kingdom are due to non-communicable diseases. And in particular, take a look at the bottom row. 1 in 6 people are now dying of Alzheimer's. And have a look in South Africa. Life expectancy has also increased, but the cost of healthcare has doubled. And we can only really use these numbers from 2000 in terms of the accuracy that we see. And non-communicable diseases, almost 60%. If you look at South Africa, in fact, we're getting sicker. This is one of the major medical aids that publish this data. Take a look at what's happened since 2008 and now in 2023. And look at the increase in chronic illnesses in children. Look at the massive increase in cancer in young people. And look at the increased mental disease. That's why it's 1/3 of causes of disability. So what's gone wrong in our healthcare systems globally? Forget about the debate on the funding or whether this is social health or national health or the NHS or any other service. What's gone wrong? I want to show you that. The current model is broken, it's siloed, we know nothing about patients before they come in, we know nothing about them afterwards. They have unintentionally abrogated their rights to the doctor. When I was in practice, why did you have your tonsils removed, man? If anyone can identify that bird, I'll stop the presentation because I think you're brighter than me. But the bottom line is, the doctor told me. Why did you have your leg removed? The doctor told me. It's fragmented, it's uncoordinated, they don't have access to their records, and they've taken no responsibility. But fortunately, in the last 10 to 15 years, we've seen the emergence of participatory healthcare. What if we made people equal and active partners in their healthcare? What if we asked them to take co-responsibility for their healthcare? But it all starts with their records. You've got to empower people with that information. And I want to come back to it. Is it enough to give people their records? And also, we're changing our perspective. Instead of thinking pejoratively of patients, the World Health Organization encouraged us to talk about people, people-centered healthcare. But even large public health organizations realize you've got to focus on the individual. Our footprints are different, our fingerprints. Our experience of pain, of healthcare conditions is different. And until we treat people on an individual, person-centered basis, we're not going to conquer these chronic illnesses and healthcare. And so we saw the emergence of person-centered health and care. And in Netcare, I kind of saw this developing and felt, wow, how do we change our organization to be more person-centered? And we realized fundamentally we've got to start by giving people records. Now, you can give someone a record who leaves your hospital with a big, thick file like this, 2 yellow-page books, and give them to someone. If you can read the doctor or nurse's handwriting, good luck. Come back to us in 6 months. That's not person-centered healthcare. And we realized we've got to digitize. But back in 2017 and 18, the idea of IT was a no-no. You know, often the common view is cost would go up 3 times, it would take twice as long, and you'd only get 1/10 of the benefits. So our board said to me, listen, Richard, you can have these lofty ideas about person-centered health and care and improving outcomes and all of those lovely, fluffy things, but show us the money. So I went around to CEOs in the US, and they said to me, have you built a business model around efficiency? And they said, no, of course not. President Obama, in his wisdom, cross-subsidized the implementation with the Obama plan of digital records in the US. The CEO of Mayo Clinic told me that he spent $2.6 billion on 4,000 beds. Work that one out. And so we decided to build our own model of efficiency so that we could at least start the process. And this is what we did. We divided it into quantifiable benefits and non-quantifiable. The reality is what I wanted to achieve with a non-quantifiable but I had to be able to pay for the system, and so those were the quantifiable benefits that we achieved. And so our strategy is comprised of 3 phases. Digitally enabled, we've entirely digitized our entire network across 7 operating platforms. It's taken us 6 years because of 2 years of COVID, which nearly destroyed us. And then the data. You know, once you start digitizing, you suddenly find you've got an enormous amount of data. We were like the little chihuahua who'd been given a big elephant bone to digest. We couldn't even get our mouths around the amount of data. We're producing 51 gigabytes of clinical data a day. And so the next phase is around data analytics, and really improving research and outcomes, and I'll talk to that a bit later. And then the most important is this: person-centered health and care. Great, you've got the records, you've put out the tram lines, and you've got the data, so what? Unless we can improve outcomes, unless we can engage with people meaningfully and improve their health span, we've missed the plot. And that's the reason why we've digitized, to fix a broken healthcare system and empower people to take co-responsibility meaningfully for their health. And I'm going to show you an exact example of this later. Is everyone with me? I never heard yes, I assume you are. So who are our partners? We chose Deutsche Telekom. I'd seen the system, a very rudimentary form of it in Hamburg, and we spent 2 years developing off that platform. We chose Apple because it's a very, very secure iOS platform, and we're one of the few mobile providers in the world. In other words, we allow doctors to have access to the records off-site. You can be sitting at home having breakfast, a cup of coffee. You can see the live results of your patient. You can be at a restaurant. You can be at a community event. You can be out. You don't have to rush to the bedside to look up what's happened. You don't have to get a grainy WhatsApp picture from a nurse which is POPIA non-compliant. You can see it yourself. You can change the drugs, and it's had an enormous impact on health, on safety. Capsule allows us to integrate IoT. Those was Qualcomm. That's the largest IoT company in the world. We're in 8,000 sites, not a single site in Africa till we've knocked on their door. And that integrates all of our ECG machines, anesthetics, infusion pumps, you name it, every piece of technology. So that this isn't a hybrid system of manual written records. This is entirely digital. And then what was critical for us was healthcare safety and patient safety. And so we bought the largest database in the world from IBM Watson Healthcare. It's now called Meritive. It's called Micromedics. It's the largest drug database in the world. Every time a doctor prescribes a drug, we check immediately its dosage, we check its side effects and its drug interactions. And it's extraordinary what that's done. I'll show you the results a bit later. And then finally, we had already implemented SAP, and that's made an enormous difference. That's our enterprise-wide system. But this is the challenge we faced. That's the record of the first transplant patient in 1967. And I put up Chris Barnard because he brought ICU medicine to South Africa from Minnesota in 1963. And you can see how beautifully it's written manually. Let me show you something shocking. That's the ICU chart from Mill Park before we started in 2018. Spot the difference. There isn't. So despite 50 years of developments in medical health and technology, taking of records hasn't changed. And amongst many of my colleagues and competitors in the market, this is still the way they take records. And so the task was enormous. We had to convert all of that into this. Took us 6 years. And the risks were enormous. Most people said you won't be able to teach our nurses how to do it. They've never had computers before. They've never had iPads. They're all going to get stolen. Our board said to me, you've got to budget for 50% of the iPads to be stolen. We were integrating all the pathology and radiology data. It was an enormously risky project. So how did we do it? We began very simply. Most of our nurses had never used an iPad, so we began by teaching them and allowing them to play Candy Crush. Get familiar, have fun on the iPad. And this was critical for us. There you can see one of the nurses said to me, one of our most senior nurses at Mill Park, said to me, Richard, I'm 54 years old. It's the first computer or iPad I've ever had. Incredible. And they've become really the pioneers, the protagonists, the evangelists of this system. We've only lost or misplaced 154 iPads out of 13,000. And so, you know, we had this pejorative view of nurses. They've led the charge on this. And what does Care On look like today? We'll just take a look at the stats. We've trained over 32,000 people on the system, allied health professionals, admin staff, doctors, nurses. At any one time, there are 5,000, more than 5,000 concurrent users. Look at that drug-to-drug alerts, 2.63 million since we started. If you had asked me in 2018, how many drug alerts have you got, Richard? I would have said very proudly, I've got the Excel spreadsheet, 218. And that's the problem with measuring quality in the private and public sector if you're not digital. You're measuring what's recorded on some piece of paper or electronics, some piece of paper or Excel spreadsheet. It's meaningless. Only when you've digitized and there is an audit trail of when that drug was given, if it was given, what time it was given, as opposed to someone filling in something and deciding whether to report it or not. And you can see the clinical data that we're collecting daily. And as a result, we've become Apple's largest customer in Africa and in Southern Africa for iPads, more than 13,000. Actually, we're the largest user of their iPads in the Southern Hemisphere, but because they have different marketing regions, we can only talk about Southern Africa. So we've digitized across all of our various provider networks, and you can see them over there. We set the standard internationally. Last year we won the International Quality Award in London. We beat the Dubai ports authorities that had spent billions on the immigration system to digitize it, and a UK-based company in the final called Leonardo, who had originally built a Spitfire and now are involved in building planes, etc. And of course, for our board, Show Me the Money, we were able to demonstrate these efficiencies and an IRR of 23%. And every year we've been able to demonstrate these efficiencies. And digitization is a gift that keeps on giving. And you can see how those crocodile jaws are widening. The little blue dots are the original budget, the whites are the projected efficiencies going forward. But you know what's very important is now to analyze that data, and we are firm in our belief on democratizing that data. We have purchased an absolute world-class database. We also use Databricks AI, which is in the top quadrant of Gartner in terms of that analysis. And that database allows us to produce synthetic data. So not only is the patient information anonymized, it's put into a synthetic form that cannot be recognized. And as a result of that, we can quite easily share that data amongst our clinicians, amongst our nurses. And we want to share it with South African research houses, and we've now made it available to all the universities for their registrars and others to come onto our database and be able to do research. Across the entire Netcare platform, we have some 5.4 million records now on the database for them to look at and conduct research. And that's important in driving research and making an impact in terms of health and science in South Africa. It's also had a profound impact on safety. You know, 60% of errors on medication occur because you can't read a doctor's handwriting. We've eliminated that. We were the first to put in digital electronic signatures back in 2020. We got approval from the Pharmacy Council. And so every script that is digitally put into the system, and it can only be put in digitally, is checked for any errors, it's checked for dosage, it's checked for side effects and drug interactions. And that's across 1.8 million scripts in Netcare. That's an enormous achievement, I don't say that immodestly. But we're also now differentiating on clinical outcome. We're measuring what matters in mental health, and I'm going to come back to this later. We're doing statistical analysis. Does our treatment work? And the only way you can do that is to measure your risk-adjusted readmission, because it's not the initial admission to hospital, it's how many times the patients are coming back. And if they're coming back all the time, well, is it really working? And so we're the first to be able to share this with medical schemes at 30, 60, and 90 days. We're also differentiating through clinical data and changing doctor behavior. Most doctors will tell you, I don't touch generics because they're cheap for a reason, they don't work. And so they choose incredibly expensive ethical drugs. But we're able to now go across our network and compare drugs across tens of thousands. This is a study across 12,000 patients where we compared a very cheap anticoagulant, which was a generic, versus a very expensive generic, a very expensive ethical, and likewise antibiotics, where the generic was 64 to 70% cheaper. In both of these studies, we found on a risk-adjusted, in other words, statistically valid analysis, there was absolutely no difference in morbidity or mortality. And so when you've got the data, as doctors will say, in God we trust, everyone else bring data, it's very difficult for them not to change their behavior. And right across Netcare, we're looking at outcomes, we're looking at care pathways, and what was considered the absolute gold standard before, we're challenging with looking at outcome analysis. We've developed the first machine learning, artificial AI-driven early detection of sepsis in South Africa and Africa. Sepsis is an overwhelming bloodstream infection. In other words, you're in an ICU and you can be in a general ward and you get a bloodstream infection. It can cause up to 30% mortality. Just through machine learning, in other words, taking 4 parameters off our electronic records without any nurse or doctor involvement, we can now predict 8 to 10 hours before that happens and intervene. We're now building one on renal failure, on heart attacks, and on readmission stats. We spent 4 years building an in-house platform on infection management to identify all the bugs in our various hospitals, but also to understand what they're susceptible to. So before doctors use the most expensive and rare antibiotic, we're able to say, actually, doctor, in this hospital, that bug is sensitive to penicillin, which costs 12 cents a dose. And that's incredibly important. And we've also got an AI algorithm to predict any infection outbreak. So all of this IT now being used with the data to improve safety and outcome and cost in our patients. And we're early on in this phase. What about our patients? So this is the most important to me. We're democratizing data for our patients as well. We're giving them a clinical record. If you download the Netcare app, once you've been in hospital, you can get a record. We've now just launched a large language model, and I want to thank Decision Inc. You're in the audience. You helped us build that model, and this is to de-jargonize healthcare. Because, as I said earlier, you can give someone a record, but if you don't understand the record, you might as well not look at it. Let me give you an example. You come into a hospital and this is what you're diagnosed with. Acute cholecystitis due to chronic cholelithiasis. As a result, we had to perform an urgent laparoscopic cholecystectomy. You're now being discharged with prophylactic antibiotics and must avoid fatty foods. What in heaven's name does that mean? But what if we said this to you? You are diagnosed with severe inflammation of your gallbladder due to long-standing accumulation of gallstones. As a result, we had to perform urgent keyhole surgery to remove your gallbladder. We're sending you home with precautionary antibiotics to avoid an infection. Because you no longer have a gallbladder and cannot produce bile salts which digest or help digest fats, please try to avoid fatty foods. Spot the difference. I'll take that as a resounding yes. And so we've given an app to our patients. And I want to show you what this app does. You can download it free. It's the Netcare app. And the first element is around ease of use to make the journey easier. Before you get into a hospital or facility, the next is whilst you're in our hospital, and then ultimately it's going to be around health span. How do we improve your health long term? Specific hospital guides I can thank nurses or doctors. You can raise a complaint. You get access to your health records at home. You get a recovery guide. You can share feedback. You can see your account information. You can book online specialist appointments. You can consult virtually. You can do your pre-admission at home instead of standing in a queue. You can join Netcare 911 and be geolocated automatically in an emergency. And so we've had over nearly 600,000 people download that app and use it. And you can see that we're now we're beginning the third phase, which is beginning to digitally engage with our patients. I want to come on to what person-centered health and care means, because this is personally for me a passion, but it's a critical element because you can have everything else and we don't achieve what it is. Well, what does it mean? You can see it's this phase over here. What does it really mean? It means putting patients at the center of absolutely everything we do. It's recognizing their journeys are absolutely individualized. And it's encouraging them to take responsibility. Obviously, we've got to treat them well, both in an acute episode and also whilst they're at home. But here's the big difference. And if there's only one slide you hold on to today, this should be it. When you come into a hospital or you sit before a doctor or a specialist or a healthcare worker, they ask what's the matter with you. Is that what's important? Of course not. It's what matters to you. It's not what's the matter with you, it's what matters to you. What do I mean by that? Let me give you an example of someone coming into one of our mental health hospitals. Okay, so what's the matter with you, sir? I can't get out of bed in the morning. I can hardly lift my head. I can't even face my computer screen at work. Wow. Okay, you've got major depression. Oh, and by the way, you've told me also that you're worried that your neighbour's trying to shoot you. You've got a bit of paranoid schizophrenia, and you like to take recreational drugs on the weekend, and a bit of cocaine. Okay, you've got a dual diagnosis. No problem. I'm going to write you a script for 6 to 8 medications. Come see me in a month. Book that with my receptionist, please. That's what's the matter with you. How motivated is the patient going to be? How compliant are they going to be? But what if we said what matters to you? Now, I know if I was sitting in that position, I'd say the following. What matters to me? I want to restore my relationship with my partner, with my significant other, with my wife, spouse. I want to re-engage with my kids. I want to be able to hold down a job and ultimately make an impact in society. Okay, well, if that's the case, the diagnosis doesn't change. But let's look at your functionality. Let's do a WODA score for you, or a PH9. You're 22, you need to be 5. No wonder you can't. It's a miracle you can even get out of bed. Now let's start measuring and giving you programs to increase your functionality. Spot the difference. Who's going to be motivated here? That's person-centered health and care. What matters to patients, what matters to you. And I'm going to give you a good example of something we've just published in Ireland at the ICOM conference there in early October of evidence of this in our network. So what does it look like? You know, we run national renal care. And we've got about 3,500 patients on it, and we gave them this app. I was personally involved in the development of this and gave them all their records. And I thought we would have 100% of people downloading it. After all, they've got no kidneys, they've got to go onto a machine, and 3 times a week for 4 hours. They're the first people who are going to download it. And as you can see from it, less than 2%, 1.3% of patients downloaded their information. Because that's what's the matter with them. They know what the issue is. They don't care. The doctor's got those records. So we brought in behavioral specialists and we said to them, our patients, what if we told you you've only got a 30% chance of surviving in the next 5 years? You've got more than a 2/3 chance of dying. Would that worry you? Of course. Do you have anything on your bucket list that you want to do beyond that? See your grandchildren grow up, see your kids getting married, I don't know, traveling around the world, climbing Everest, whatever. Of course, bet your bottom dollar. Okay, if that's the case, we're going to give you a little dashboard on a traffic light basis of red, amber, and green of 6 or 7 parameters that can change your life. And you just measure these and focus on them. And they're going to make you feel a lot better, but they have a very good chance of improving longevity. But I ask people in this audience, 2 years later, having done that, how many people do you now think we downloaded that app versus 2%? Silence. Anyone want to gauge? There's no, anyone? 30%? That sounds like an auction. Be more generous. Sorry? 7%. 70%. Anyone else? 80%. 94%. Isn't that incredible? Yeah, you can give a bit more enthusiastic clap there. Yeehaw! Halala! Come on, man. 94% of people are doing it. We're not giving them a toaster. We're not giving them extrinsic motivation. You've got points from this medical scheme or from this pharmaceutical chain or whatever the case may be. You're not getting a discount on your airline tickets. It's an intrinsic motivation because I want to live longer and I want to be healthy. And when you empower patients with participatory health, that's what you get. It's not a slot machine. I've got to pay you to check your blood pressure. Okay, so we did that. Now look at this. 94% are registered. They're spending up to 16 to 22 minutes on it. And, you know, they can measure their fluid intake, which is critical for a patient who's in renal failure. They can look at their diets, look at their outcomes, etc. And you can see physical well-being and mental well-being has improved, but those are simple scores. What is amazing to us is that we've been able to show that blood albumin, which is the protein we have in blood, which traditionally is shed by these patients through their kidneys, has statistically increased in patients that download the app more than 7 times a month. Wow. That is absolutely extraordinary. We've seen hemoglobin increase, but it hasn't increased to statistically valid levels. So by not changing any drugs, by not giving people various infusions, by simply changing behavior and getting them to become engaged, taking co-responsibility for their health, measuring fluid outcomes, looking at their diets, downloading research articles, being focused on their own health, we have improved one of the most significant factors in well-being and longevity in renal patients. And that's living proof. We published this for the first time at the ICON conference in Dublin this year in early October. Okay, so I'm almost finished, folks. What's the ultimate prize? What are we trying to achieve with all of that, and what should we all be chasing? Let's assume we've digitized. Let's assume we've given patients their records. I think it's this. What if we aggregated everyone's records? Not just their medical records, but also their wearables. Because if you'd asked me in 2018, you know, what's the end goal here? I would have said electronic medical records. It's not. It's medical records and your wearable data, your heart rate variability, and other issues that we deal with. It's critical. So what if we were able to do that and interpreted that for patients and put it into a format that actually matters to the individual? Can you imagine the impact of that? And it's actually creating a digital twin, not just a digital twin, an identical digital twin of yourself. And what if we could reduce morbidity? What if the real challenge is to move health span or health span to meet lifespan? That you only really got sick a week before you were due to die. You didn't need a hip replacement at 52. You didn't need to have XYZ done to you because you've expanded your health span. And so I want to end by saying if we can achieve that, It's not just about living longer, it's about living better for longer. And that's the real purpose of why we have digitized, why we have a data strategy. It's to be able to drive person-centered healthcare, empowering individuals to change the way they behave, to take cognizance of their own healthcare, to have their app, their healthcare app on the front face, on the home page of their mobile phones. And that's what I'd like to encourage each and every one of you out here to do, is don't wait to digitize. Don't wait to give patients their records. Do it in a way that they can understand it, but let's encourage globally people to drive the idea of health span. We'll reduce the overall costs of healthcare, there's no question about it. But we'll also improve overall sense of well-being and longevity. I want to stop because at every one of my talks, I talk about this. We are the global leader in sustainability, not just in Africa, environmental sustainability, but also globally. We've won over 52 awards. We started environmental sustainability in 2013, long before the word was even coined, ESG. And I want to show you a project that we've been doing, and I want to ask you to support us in some way or form. You know, in South Africa, we have about 15 million children under the age of 14, under the age of 14 at school. 58% of them are in Tier 1 and 2, which are the poorest of the poor. They get 2 meals a day, their parents can't afford to pay school fees, and 80% of the parents are unemployed. But in the research we've done, at least 20 to 30% of those kids have no shoes whatsoever. And I want to show you something. And so what we do in Netcare is we take 20 IV bags, 20 drip bags, and we make a pair of school shoes. So when you ask one of our ICU sisters, what does she do? She'll tell you, I make school shoes. And these pair of school shoes are completely recyclable. They've got an SABS stamp of approval. And you know what the cost of this is? If I ask you, what's the cost of a cappuccino? $35. That's what these shoes cost. Join us. It's an NGO. It's a Section 18A PBO registered. You'll get back 40% for tax anyway. But we have distributed 380,000 of these. We want to get to 1 million. And if you've got a CSI initiative or you're doing something, there's a desperate need to get shoes on our children who have to walk many kilometers, some of them, through mud and streams and whatever the case is, to get to school. Many kids don't come on in winter because it's too cold. You know, in our first school we went to in a squatter camp, we asked the parents to come and hand out the shoes. And a 14-year-old girl got up for a 6-year-old sister. It was a child-led family. When we were doing the research in KwaZulu-Natal, I asked a little 6-year-old boy who put on these shoes for the first time. I said to him, what does it feel like? You know what he answered me? Like the president. That's what he feels like. So I'd really ask you to join me. It's called My Walk Made with Soul. You can look up the website on it. And let's put shoes on the future presidents of South Africa. Thank you very, very much.
Do you have any questions? Are there any questions for Dr. Friedland? I'm sure we can take one or two. Sure. Yeah.
Wearables and medical records. I think the universe of potential for data sources is much bigger than that. So I'm curious, like a lot of the things we find is in behavioral, psychosocial attributes of our patients, whether they lose their job or have a problem with their spouse. Those are the things that's actually driving quite a lot of the health-seeking behavior. So I was just curious, like, why stop at wearables and medical records?
Yeah, it's an excellent question. Thank you very much. We're not. Watch this space carefully. We absolutely believe that taking into account the psychosocial issues, challenges, what's happening, mental health is absolutely critical. And you don't measure that necessarily only with someone's heart rate, etc. So we're on the same page. And watch the space carefully. Something's coming out on that.
I think it really shows that there's a lot of work that has been done in the country and even outside the country to make sure that eventually we can have digitization of records that support good quality healthcare. I just want to find out from the your app. You said it also provides patient recovery guides, and are those guides informed? Are they also AI kind of backed? By AI backed, I mean, like, is it customized for each patient's conditions and all other factors that have been collected through the app, or is just standard guides? Thanks.
So if I hear you correctly, because there was a bit of a noise, you're asking, sir, whether our patient guides are customized to the individual patient. At the moment, they're not. We are on a very significant AI journey. We will use the same machine learning that we're using on the sepsis model and other neural networks to be able to measure what the outcomes are and advise people on an individual basis, but we're not there yet.